Hi, so today we are going to discuss about anemia management in chronic kidney disease patients. Anemia of renal disease is a hypoproliferative anemia resulting primarily from deficient erythropoietin or diminished response to it. It tends to be normocytic and normochromic. Treatment includes measures to correct the underlying disorders and supplementation of erythropoietin and sometimes iron. Erythropoietin supplements like alpha poietin, beta poietin, or SERA, continuous erythropoietin receptor agonist. Fatigue, weakness, headache, and irritability are commonly seen in people with anemia. Kidoko Anemia Clinical Practice Guidelines identify iron deficiency as the most commonly encountered anemia in CKD patients. Hemoglobin measurement is the gold standard for assessment of the severity of anemia. Hemoglobin is measured in grams per 100 ml and each grams carry 1.34 ml of oxygen, or in other ways, one hemoglobin can carry 4 oxygen. So in here is the hemoglobin threshold for the different age groups. The first age group is 6 months to 5 years. Its threshold should be 11 gram per deciliter. And 5 to 12 years threshold is 11.5 gram per deciliter. And the age 12 to 15 years, the threshold is 12 gram per deciliter. In adult with the CKD, for female age 15 years or older, anemia is diagnosed with the level of less than 12 gram per deciliter or 120 gram per liter. For men, hemoglobin level of less than 13 gram per deciliter or 130 gram per liter is diagnostic of anemia. Diagnostic hemoglobin level requires further anemia evaluation to identify other potential causes, other than assuming the causes is related to reduction in endogenous erythropoietin. Evaluating red blood cells RBC indices assists the provider with identifying the morphological type of anemia. MCH or mean corpuscular hemoglobin. This will evaluate amount of hemoglobin in the cell and reflect the colors like weight and mass. MCH is the mass of the hemoglobin per RBC and described as normochromic, hypochromic or hyperchromic. Next one is MCV or mean corpuscular volume. It will evaluate the size. The MCV evaluates the size which identify if the RBCs are normocytic, microcytic or macrocytic. Mean corpuscular hemoglobin concentration or MCHC evaluate the concentration of hemoglobin like average weight in the cell. The MCHC is the ratio of hemoglobin mass to hemoglobin volume and reflects the concentration. The RBC indices identify the morphological characteristics of RBC. In CKD, anemia is generally normochromic, normal MCH, and normocytic, that is normal MCV, and long-standing iron deficiency anemia in both microcytic or decreased MCV and hypochromic decreased MCH. Folate and vitamin B12 or cyanocobalamin deficiency are unlikely in the CKD but are routine in the workup for anemia. Folate and vitamin B12 would show a macrocytic RBC, elevated MCV. Inherited thalassemia disorder often cause microcytic RBC or decreased MCV. When evaluating for iron, it's very important to assess both the availability of iron to support erythropoiesis as well as the patient's iron stores. Transferrin saturation or TSAT measure the availability of iron, and iron stores are commonly evaluated by serum ferritin level, but in CKD, the inflammatory process can increase the serum ferritin levels. Bone marrow aspiration remains the gold standard for the evaluation of iron storage, but is costly and inconvenient. According to Kidogo, most people with CKD have normal storage of iron in the bone marrow. Treatment of iron deficiency. Both the risk and benefits of iron therapy must be assessed by the clinician. Recall. Oral iron is not absorbed in the stomach but in the duodenum and in the proximal jejunum as well. Oral iron is inexpensive and must be taken with some precautions to obtain the best absorptions. Food decreases absorption, so oral iron should be administered 2 hours before meals. Antacids interfere with absorption of iron and should not be taken within 4 hours of taking oral iron. Oral ions can cause nausea, vomiting, constipation, or diarrhea and seems to be dose dependent. People who have gastrointestinal intolerance to oral iron tablets may experience favor side effect with ferrous sulfate elixir. Daily dosing of oral iron in adult with iron deficiency is 150 to 200 mg a day of elementary iron is in divided doses. Elementary iron in various iron precautions are a 325 mg tablets of ferrous sulfate contain 65 mg of elementary iron. A 325 mg tablet of ferrous gluconate has 36 mg of elementary iron, and a 325 mg tablet of ferrous fumarate has 98 mg of elementary iron. Iron administration must be guided by the clinical status, response to iron therapy, recent blood losses, treatment with erythropoietin stimulating agents ESA, and outcome of ferritin, TSAT, and hemoglobin levels. For those who do not tolerate oral iron, parenteral iron can be given, but this route of administration carries a risk of anaphylactic types of reactions. Manufacturer recommend the test dose of iron salt be given the weekly interval of first, second, and third weeks. A test dose is recommended 25 mg over 5 minutes while observing the patients for reactions. If no reactions occurs by 60 minutes after a test dose, then the remaining dose is administered at 75 mg at the rate of less than 50 mg per minute and diluted in 250 to 1000 ml of normal saline. 60 minutes monitoring period is a Kidogo anemia guideline for IV dextrans and for IV non-dextrans ions. Parenteral iron should always be administered by a trained person who can provide resistive measures and treat adverse reactions. During 4th week, dosing 100 mg given intravenously over 5 minutes at less than 50 mg per minute can be initiated. And this can be repeated until the prescribed dose and lab values are reached. Patients with systemic infections should avoid receiving parenteral ions. Always see the specific dosing recommended by the manufacturer for infants and children. Ferritin and transferrin saturation must be evaluated every 3 months during erythropoietin stimulating agent treatments or change in ESA dose. The point where there is a decision to stop or continue iron therapy and periods of blood loss. Iron and ESA therapies are used to treat anemia and to decrease red cell transfusions and their risk. ESA is used to treat anemia by stimulating the erythroid progenitor cells to form and then release reticulocytes in the bone marrow to mature into erythrocytes. Increase in hemoglobin as seen with ESA approximately 10 days after initiation of treatment. ESA increases the risk of stroke by increasing peripheral vascular resistance, blood pressure, and blood viscosity. In 2011, the FDA issues a black box warning that ESAs carry greater risk for death, serious adverse cardiovascular reactions, and stroke when hemoglobin target exceed 11 gram per deciliter. The FDA recommends that ESAs are initiated when hemoglobin falls below 10 gram per deciliter to decrease the need for RBC transfusions. In 2011, Burns, a nephrologist, has questioned these recommendations because it was based on a limited number of trials and patients' populations are applied to the whole population with CKD. Kidogo Anemia Clinical Practice Guidelines 2012b note that therapy needs to be individualized. Individuals who suffers a decreased quality of life may have improvement in the symptoms when receiving ESA therapy and target hemoglobins over 10 gram per deciliter. Before treatment of anemia with ESAs, individuals with CKD must have all the correctable causes of anemia addressed, while balancing the risk and the benefits of the treatment. Considering hypertension, stroke, and risk for loss of vascular access that occurs with higher hemoglobin level. Adults with CKD on maintenance hemodialysis should be started on ESAs to prevent drops in hemoglobin below 9 gram per deciliter. Dosing of ESA is based on the body weight, clinical evaluations, and hemoglobin levels. Dose adjustments are made on the same criteria include current ESA dose. Holding ESA dose is not recommended during therapy and lowering the dose is preferred when the hemoglobin has increased too rapidly or exceeded the target. Subcutaneous or intravenous route of administration of ESA therapy is used for hemodialysis patients and subcutaneous route for individuals with non-dialysis and peritoneal dialysis patients. And the frequency is based on the patient's tolerance, CKD stages, and treatment settings, type of ESA, and preference. Hemoglobin levels should be assessed every month during the initiation of ESA therapy, monthly for the individual with CKD and on maintenance hemodialysis. To avoid allosensitizations, RBC transfusions are to be avoided in those individuals who are eligible for organ transplantation. Transfusions may be indicated in those with ESA resistance, bone marrow failure, stroke, malignancy, or other hemoglobinopathies where ESA is not recommended or ineffective. Decisions to transfuse is not based on one isolated hemoglobin value, but on individual symptoms, stabilizations of hemorrhagic conditions, and preoperative corrections where the benefits outweigh the risk. In those patients who are receiving frequent transfusion, it is important to monitor ferritin level. Thank you for watching.